The group is like one of the special things in my life. Larry and I actually got together a long time ago in the mid-90s when I was a dean and he was a dean, and we had discussed the possibility of putting together a group that would really kind of do something different, and we're not afraid to take positions on certain issues. So we actually convened a meeting in Dallas. I was actually at Baylor at the time, and we hosted the meeting at the airport hotel, and we invited Larry, of course, Art Dagoni, Hal Slavkin, Mike Alfano, and that was the beginning of the Santa Fe group. We had conversations about the possibilities of what we could accomplish as a collective, and then we all went to Larry's house. We invited one or two other people, including Richard DeStatio, who was the former president of the American Dental Association. And when that meeting was over, his entire house was littered with paper on walls that had writing on it. It was a wonderful kind of a thing. We were brainstorming, and we had to come up with a name. So we came up with the Santa Fe group, mainly because we were in Larry's house in Santa Fe. There's a couple of issues right off the bat. One is that the elderly population is growing by significant margins and proportions. And there's clearly not enough people to take care of them. And there's not enough competency within the ranks of people who are already providers, either dentists, dental hygienists, or even medical providers to take care of this population. So it seems that the first thing we need to do is to make sure we have some strategy to incorporate geriatric education and clinical training right in the heart and the fabric of dental education. And we need to expand residency programs to deal specifically with those issues. There used to be a program, I think it was funded by HRSA, where physicians and dentists did residency training in geriatrics side by side. I don't know if that program exists, but it should be expanded. That's the kind of thing we're talking about. And also, I think most dental schools now at least talking a game of interprofessional, interdisciplinary education. That's where the rubber would meet the road here, because you cannot treat or diagnose persons who are of age, if you would, because most of the time, without having other competencies available from other professionals, because they come in with a variety of different medically compromised conditions or just complex medical cases, polypharmacy patients, and you really need to access other healthcare professionals to do this. I also think there's a great opportunity for the other kind of provider that may come on the scene here, the comparable nurse practitioner or physician assistant, to be much more a part of the dental profession than we have ever thought about in the past, because you can't train enough dentists to take care of these populations. And then there's that whole caregiver area where if we could figure out a way to educate the caregivers, we would have a much bigger cadre of people to help take care of the needs of the elderly population. Well, I mean, you know, the baseline is you have to really contact your Congress people and really become a strong, not only advocate, but a sort of an individual who's willing to put their mark on the table, so that you would be essentially debating the merits of having oral health care as part of the healthcare reform issue. And that's not a simple task, because there's a lot of political barriers here that we face. But for example, I think we make a mistake if we don't do something about Medicare, not Medicaid, because Medicare, to my view, it's always been a tragedy that dentistry is not a part of Medicare. And there are people proud of that because the way they look at, you know, fee-for-service dentistry, they don't want government interference. But the truth of the matter is Medicare is where the really big federal dollars are. And even in the era when dentistry was having difficulty with class sizes and people were busy, they thought there was too much busyness, not enough busyness in practice, that was an era when if we were on Medicare, that would have never materialized, because there would have been terrific access to patients. And Medicare provides a lot of opportunity there. And frankly, that discussion is not even taking place. So that's one area I think we've missed the boat on, and we're going to miss it on this time too, because people are shying away from it. The second thing is, I think we should make sure that there is no such thing as a state that does not have adult Medicaid. That's been a tragedy because, as you heard some of the people talk earlier today, Medicaid is a place where you could really make things happen, where reimbursements can really work. So I think those are the kind of things to do. And then finally, I guess my admonition would be we have to figure out a way to get the consumers excited about this. You have to show some sense of urgency to the consumer, because once the consumer gets involved, they vote. Congress takes note of it. Other than that, it's just us talking to sort of the converted. Nutrition is a very hard thing to get a handle on in terms of its effectiveness. That's a great, by the way, potential clinical trial to see how really effective nutrition interventions would be in a prevention program related to the geriatric population. I do not think it's ever been done, frankly, in the dental field. The second thing is there is no doubt that the caloric intake as you get older changes, and you become much more prone to have fat deposits and obesity. So we need to counsel and prevent those kinds of diseases because they're related directly to inflammation, and that's related to that whole cascade of chronic diseases people have.